Welcome to another episode of Med Madness, where we delve deep into essential topics for USMLE preparation. Today we will explore the intricacies of fetal heart rate tracing, an essential aspect of obstetric care. Fetal heart rate monitoring plays a crucial role in assessing the well-being of the fetus during labour, and understanding the different patterns and their clinical significance is vital for every medical professional. Let's begin with fetal heart rate variability, a key indicator of fetal health. Variability refers to the beat-to-beat fluctuations in the baseline fetal heart rate. These fluctuations are categorized based on their amplitude. First, we have absent variability, where the amplitude is undetectable. This pattern is considered abnormal or intermediate and may be caused by several factors, including the use of CNS depressants such as narcotics, alcohol or recreational drugs. Temporary fetal sleep prematurity and fetal hypoxia can also contribute to absent variability. Minimal variability, defined as fluctuations of less than or equal to 5 beats per minute, shares similar clinical significance. It often indicates an abnormal or intermediate pattern and can result from CNS depressants, temporary fetal sleep, prematurity, or fetal hypoxia. Now let's talk about moderate variability, which is considered a normal pattern. This is characterized by amplitude changes of 6 to 25 beats per minute and is reassuring as it suggests that the fetus is well oxygenated and has an intact autonomic nervous system. Finally, we have marked variability, which refers to fluctuations greater than 25 beats per minute. The clinical significance of this pattern is unclear and requires careful monitoring to determine its implications. Next, let's discuss the baseline fetal heart rate. Fetal tachycardia, defined as a baseline heart rate exceeding 160 beats per minute, can be associated with several conditions. The most common cause during labour is maternal fever due to intraamniotic infection, also known as Chorioamnionitis. Other causes include medication adverse effects, such as beta agonists, fetal hypothyroidism, and fetal tachyarrhythmia. Conversely, fetal bradycardia, characterized by a baseline heart rate below 110 beats per minute, can result from maternal hypothermia, medication adverse effects like beta blockers, fetal hypothyroidism, and fetal heart block, often associated with maternal antibodies like anti-Ro and anti-Ley. Moving on to intraamniotic infection, this is a significant concern during labour. It arises from polymicrobial vaginal bacteria ascending into the uterus. Clinically, it presents with maternal fever of 39 degrees Celsius or higher, leukocytosis exceeding 15,000 per cubic millimetre, and purulent amniotic fluid. The risk of intraamniotic infection increases as labour progresses, especially after membrane rupture. Management involves antipyretic therapy, broad-spectrum antibiotics, and delivery to prevent fetal morbidity and mortality. Now, let's focus on the purpose of fetal heart rate monitoring. The primary goal is to continuously assess for signs of fetal hypoxia and metabolic acidosis, which can lead to fetal compromise. Key features monitored include the baseline heart rate, presence of accelerations and/or decelerations, and heart rate variability. Normal variability, characterized by amplitude changes of 6 to 25 beats per minute, is reassuring and suggests good fetal health. In contrast, persistently absent or minimal variability can indicate fetal metabolic acidosis and impending fetal compromise. However, certain medications, such as opioids like morphine, can cause transient absent or minimal variability due to fetal CNS depression. These changes are typically temporary and resolve as the medication's effects diminish, requiring only continued monitoring. To illustrate these points, let's consider a real-life scenario. A 28-year-old pregnant woman at 39 weeks of gestation presented to the labour and delivery unit with a fever of 39.5 degrees Celsius and ruptured membranes for over 18 hours. Fetal heart rate monitoring showed a baseline heart rate of 170 beats per minute with minimal variability. Given the maternal fever and prolonged membrane rupture, the clinical team suspected intraamniotic infection. The patient was started on antipyretic therapy and broad-spectrum antibiotics. Labour was augmented to expedite delivery, and a healthy baby was born with no signs of infection. Understanding fetal heart rate tracing is essential for ensuring the well-being of both the mother and the fetus during labour. Recognizing the different patterns and their clinical significance allows healthcare providers to make informed decisions and intervene appropriately. Thank you for tuning in to this episode of Med Madness. Stay tuned for more in-depth discussions on key medical topics. Until next time, keep learning and stay passionate about medicine.